All right. Can you all hear me?
Yes.
Okay, cool. So today we will, yeah. So today we'll be talking about neuropathy. We'll briefly go through what we studied yesterday. So yesterday we did paraparesis, and we started off by talking about uh, what kind of lesions can cause paraparesis. We spoke about how it could be an upper motor neuron lesion or a lower motor neuron lesion, and how an upper motor neuron lesion would be a dorsal myelopathy, and a lower motor neuron lesion could be a lumbosacral myelopathy or a root lesion. And there we discussed that it could be a conus medullaris lesion or a cauda equina lesion. And then we spoke about it. If we come further down, it could be a neuropathy or a myopathy or a neuromuscular junction. And we spoke about the characteristics of different kinds of myelopathy, and Brown-Sequard syndrome or an anterior myelitis or a posterior myelitis. And we spoke about the different types of pain that you can get, and which is funicular and radicular, and Lermit's sign. And we spoke about claudication. So today we'll be, yes, part I am recording today. Thanks for reminding me. So today we'll be speaking about neuropathy, and the first thing to know about neuropathy is that let's recap what you already know about neuropathy. You know that neuropathy is an LMN lesion. Okay, so as soon as you say that it is LMN, you already know certain things about neuropathy. You know that the patient can come with weakness, the patient will come with atrophy, hypotonia, decreased or absent reflexes, and the patient may come with fasciculation. Now, usually fasciculation is not a characteristic of neuropathy. You usually get fasciculation if the muscle is involved, or if your anterior horn cell is involved. So, but the other weakness, atrophy, hypotonia, and decreased reflexes are all part of LMN lesions, and they're all seen in neuropathy. What is classical about neuropathy is that along with this, you also get sensory involvement. Okay, so you need to remember that motor and sensory involvement makes an LMN lesion more likely to be because of the nerve and less likely because of muscle and neuromuscular junctions. Now, all this you already know. So let's go a little deeper into specifically neuropathy. And the most important thing you have to know about neuropathy is that you have to know the nerves. Without this, it is very difficult to evaluate a case of neuropathy. So let's just quickly revise the nerves of the body. Okay, so your upper limbs and your lower limbs. Your upper limbs will have, from the spine, you will have your brachial plexus. From the brachial plexus, you have your axillary nerve, you have your musculocutaneous nerve, you have your median nerve, you have your ulnar nerve, and posteriorly you have your radial nerve. Okay, so these are the nerves of your upper limb: axillary, musculocutaneous, median, ulnar, and radial, and they're all coming from your brachial plexus. Now, in the lower limb, you have your lumbosacral plexus, and the main nerves that come out are, hang on, I'm just going to be muting everyone. Yeah. So, can you all hear me? The main nerves that come out from the lumbosacral plexus are your femoral. So this is anterior and this is posterior. So you have your femoral and your obturator, and from your femoral you will have your saphenous, and posteriorly you will have your sciatic, and from your sciatic you will have your tibial and your common peroneal nerve. Okay, so the nerves to remember are obturator and femoral anteriorly and saphenous in the leg, and posteriorly sciatic, common peroneal, and tibial. So roughly, if you know these nerves, then you will already have an idea of uh, if there is a lesion, then what can be the nerves involved to cause that lesion. And that is why it's important to know the basic distribution of the nerves. Now, how do you evaluate a neuropathy? So, just like any other symptom in neurology, you go where, what, and why. Okay. So, the first thing to know is where is the lesion. So, both from history and examination, you have to find out where the symptomatology lies. Now, what can be the types of symptoms? So as we discussed, a nerve can contain motor and sensory fibers. Okay. Now let's look at this a little more in detail. So let's say this is a cross section of a nerve. Okay. So we have just sliced the nerve in half and we are looking at the cross section. So inside the nerve, you have multiple layers. So you have your epineurium, you have your perineurium, endoneurium, and inside the nerve, you have these bundles called as nerve fascicles. And inside these nerve fascicles, you will have tiny dots of nerve fibers. Okay, like this. So most of the nerves are mixed nerves. And by mixed, we mean that they contain both motor and sensory. I say most. There are some pure sensory nerves and there are some pure motor nerves. We're not going to go into detail of that, but in general, most of the limb nerves, most of the nerves that we just discussed, all the nerves that we just discussed here are mixed nerves. So that means that they both they carry fibers from the spinal cord outside. They carry fibers from the spinal cord into the muscle, which is the motor nerve, and they carry fibers from the muscle and the skin and the bone and the joints back to the spinal cord, which is the sensory nerves. So most of the nerves are mixed nerves. So if a nerve is damaged, so supposing you take this example, if this nerve is damaged for some reason, there is a cross section, somebody cuts the nerve, like we just cut the nerve, then both your motor and your sensory will go. And so this patient will come with both weakness and sensory loss. Now, the weakness part is easy to understand. Whichever muscle that particular nerve is supplying, that muscle will not be able to move. So that is easy to understand. But sensory loss, we need to look at a little bit more in detail because there are two types of sensory loss. Now, if you remember, yesterday we discussed in the spinal cord, we discussed there were two types of sensory tracts. So one is the lateral spinothalamic and one is the dorsal column, the posterior column. And we discussed that the lateral spinothalamic contains pain and temperature, and your dorsal column contains pressure and vibration and joint position sense. Now, the reason that these two are in separate tracts is because the nerve fibers that come to these tracts are different. So the nerve fibers that come to your posterior column are much thicker and they are myelinated. Okay, so we'll discuss this in a second. What does myelination mean? But these are myelinated fibers, whereas the fibers that come to your lateral spinothalamic that transmit pain and temperature are thinner, and they either don't have myelin or they have very thin myelin. Okay, so they are thinly myelinated. So that is the difference between these two. So in a nerve fiber, if you take a cross section of the nerve fiber, there will be some myelinated fibers, there will be some thinly myelinated fibers, and there will be some fibers that have no myelin at all. Now, what is the characteristic of this different types of nerve fibers? Why is it like that? So let's just look at the different sizes of nerve fibers. So supposing we draw this sort of a triangle, and this represents your nerve thickness. Okay, so the nerve fibers that are maximally thick, so this goes from A alpha, A beta, A delta, and C, and it can also be called 1A. It can also be called 1A, 1B, 2, 3, so on. But basically, the nerve thickness goes on decreasing, and the fibers of your largest thickness are your motor fibers. After this comes your sensory, that goes to your posterior column, that is joint position sense and vibration. And after this comes your pain, temperature, and finally autonomic. Okay, so your motor is the largest, then comes two types of sensory, and then comes autonomic. So your autonomic fibers are the thinnest one. So in a nerve fiber, usually all of these different types of fibers are there. So if it is a complete neuropathy, so if there is a traumatic neuropathy, if it is a cut section of a neuropathy, if there's a nerve transection, then all of these fibers will go. But suppose there are certain diseases that affect only, say, your large fibers. So only your large fibers are affected. Then you will have a patient who comes only with weakness and posterior column sensory loss. And suppose you have a disease that only comes with small fiber weakness, then the patient will come with only pain, temperature, and autonomic dysfunction. Okay, so this is why it's important to know which nerve fiber does what role. And conversely, if a patient is coming with one of these two symptoms and you are very sure that the other symptoms are absolutely normal, then you already have a differential diagnosis in your mind that this could be either a large fiber neuropathy or a small fiber neuropathy. Okay. All right. Um, so now you have completed so much. So let's move on from here. A nerve will, how will a nerve distribute in our body? So there are two types of distribution that we have to remember, that if a patient is coming with, say, sensory loss, and he says that he has sensory loss over the hand, we have to figure out, is the sensory loss following the pattern of a nerve or a dermatome? Now, what does this mean? What is a dermatome? A dermatome is the area of skin that is supplied by a single vertebral segment. So it could be a spinal segment, sorry. It could be either C3 or C5 or from anywhere from C2 all the way to S5. Each segment will supply one particular portion of skin, and that is called as a dermatome. So derma is skin. So you can use dermatomes to figure out if there is a spinal cord lesion. You can figure out exactly where that lesion is by localizing which patch of skin is involved. Okay. Now, why is the pattern of a nerve different from a dermatome? Because a nerve can come from several dermatomes. So, for example, ulnar nerve can be coming, the root value of an ulnar nerve can be C7, C8, and T1. All these three nerves can come together and form the ulnar nerve. So if an ulnar nerve is gone, then you will have dermatomal loss of all these three, or you may have only one of them if your other nerves are overlapping with this. We won't go too much into detail about this because it's not, we'll end up discussing dermatomes for a long time, but it's basically just important to remember that you have to differentiate between a nerve distribution and a dermatomal distribution. Okay. And I'll give you a quick look at which dermatome supplies what. So C1 does not supply anything. C2 supplies your occiput. C3 will supply the back of the neck, the nape of the neck. Now C5 will be your shoulder tip. C6 to C8 and C8 will supply a hand. Usually C7 is your middle finger. T1 is your axilla. T4 is the nipple. T10 is umbilicus. T12 is pubis. Now L3 is your knee. S1 is your little toe. And S3 to S5 is your perianal area. And the way that a dermatome is distributed is that, supposing if this is a limb, your dermatome will come out from the spinal cord and it will wrap itself around the limb. Okay, so try and imagine that each dermatome is wrapping itself around the limb. So you will never find a dermatome in an absolutely straight line. There will always be a curvature. And the reason for this is that in the embryological stage of development, that is how the embryo is wrapped around like a burrito. Each limb gets wrapped around by the nerve, and that is why the dermatomal distribution also follows that curve. All right. So I think that covers your basic anatomy. Now, this much would be enough to figure out where is the lesion, because we will take history and examination, and we will already have an idea as to which limbs the lesion lies in and what kind of deficit the lesion is causing. So is it a pure motor, or is it a sensory, or is it a mixed? So what this will ultimately give you is you can tell if it is a mononeuropathy, a multifocal mononeuropathy, or a polyneuropathy. Now, what does this mean? Suppose you have a lesion involving only your ulnar nerve. That's it. One single nerve is gone, then it is a mononeuropathy. Suppose you have an ulnar nerve on one side, a median nerve on the other side, or a common peroneal nerve in your lower leg, then it is a multifocal mononeuropathy, which basically means two or more nerves are involved in different sites. And a polyneuropathy means multiple nerves. So that means that in the same limb, you can have ulnar, median, and radial gone, or you can have any combination of involvement is a polyneuropathy. So this is important because there are actually specific causes of each one of these three presentations. So if it is a mononeuropathy, there are actually very few causes that cause mononeuropathy. That is a single nerve lesion. Like for example, if the patient comes with a wrist drop or a foot drop only on one side, that means that there is only a single nerve involvement, then it is usually traumatic. So you've heard of Saturday night palsy, in which the patient's arm is compressed against the back of the chair. So there is compression. So traumatic neuropathy or a compressive neuropathy. Okay. Or it could be an early mononeuritis multiplex. That is a multifocal mononeuropathy. So sometimes in an early stage of a multifocal mononeuropathy, the patient may come with only one nerve involvement. But eventually, gradually, there are other nerves also getting involved. Now, what are the causes of multifocal mononeuropathy? Here there are different causes. One of the commonest causes in India is leprosy, and you can also have diabetes mellitus, and you can have something called as MMN, that is multifocal motor neuropathy. I'm not going too much into detail in this, but you just have to remember leprosy and diabetes as the important causes. And again, polyneuropathy, there are multiple causes. Everything except for what we've just discussed can ultimately end up in polyneuropathy. Now, regarding what is the lesion, there is one more important differentiation that you should remember, is that there are two types of neuropathy. It can be axonal and it can be demyelinating. Now, if you remember, we spoke about demyelinating over here. We spoke about the myelin sheath. So we spoke about how the posterior column fibers have myelin, and the lateral spinothalamic tract fibers do not have myelin, or they're thinly myelinated. So now we have to talk about what is myelination. So this is the nerve, and this is the cell body of the nerve, and there is an axon impulse that goes down all the way, and it is sending a signal. But the problem is that this signal transmission is very slow. Okay. And there are certain things, there are certain actions in the body that require a much faster transmission. So like what? So if you are standing and you're walking and you suddenly trip, then you need the sensation of you tripping, that is from your joint position. Your joint position sense will tell you that you have lost your balance. You need that sense to quickly come up to your spinal cord, and you need the spinal cord to quickly send a return response back to correct your balance. So both of these things require much faster transmission. So your posterior column fibers and your motor fibers both require faster transmission. So this is why both of them have something called as myelin. Now, what is myelin? Myelin is a covering of your nerves. Okay, it is on both sides. It surrounds the nerve, and there are small gaps in the middle. Okay, so what this does is this insulates this part of the nerve, and it allows this transmission that is coming from your cell body to jump from gap to gap. This gap is called as node of Ranvier, and because it jumps from gap to gap, the transmission is much faster. Okay, so because of this faster transmission, we are able to both receive information and send back information much faster. Okay, is this concept clear, or should I explain it a little more? Just let me know on the chat. So right, so this is the concept of your myelin. Now what happens if for some reason your myelin sheath is damaged? Okay, now only your myelin sheath is damaged, your axon is still fine. Okay, this is your axon, and your axon is still fine, but only your myelin sheath is damaged. So then what will happen? Will the transmission stop? No. So transmission is still there, but it'll be slow. What will stop? These two actions will be harmed. Your motor and your posterior column fibers, the transmission will be slowed down so much that there will be neurodeficit. So that means that there will be weakness and there will be reflex loss, that is areflexia, because your reflexes also use your posterior column, that is your large fibers. Okay, so in a demyelinating condition, you will have weakness, quite severe weakness, and you will have areflexia. Okay, now supposing your myelin sheath is actually okay, but your axon is damaged, then what will happen? So now your transmission itself is gone. Okay, now along with transmission, what is also going through is your nutrition. Now because your axon is damaged, there is no transmission of nutrients to the distal part of the nerve. So this is your distal nerve. So your proximal nerve is getting nutrition because it is closer to the cell body, but your distal nerve is not getting nutrition, which is why you get damage to the distal part of your nerve. And gradually, this distal nerve damage will go on progressing. And if the neuropathy persists, you will have damage in your proximal part of the nerve. So this is called as dying back neuropathy. Okay. So this is called as dying back neuropathy. Now, and this is a sign of axonal damage. So how does this clinically present? The patient will come with symptoms of, he may come with symptoms of weakness, but the weakness will be distal, and it may involve all four limbs. It may involve the lower limbs first. Now, why will it involve the lower limbs first? Because the lower limb fibers are longer. So by simple physics, it takes more time for the nutrients to reach the end of your lower limbs than for your nutrients to reach the end of your upper limbs, because they are shorter. So that is why your lower limbs may get involved first. And what happens is your lower limb involvement will progress up and it may reach till the knees. And then your upper limb involvement may start and it may reach to the elbows. So this is a classical feature of axonal neuropathy. And this type of presentation is called glove and stocking presentation. Okay. Now, what else will happen because of lack of nutrients to the distal part of the nerve? You will get atrophy. Now, the reason for this is that your the muscles at the end of the nerve, they are not getting any stimulation. So there's no acetylcholine release from the end of the nerve terminal. So gradually your muscles start becoming disused and they go into atrophy. Okay. And the other characteristic of an axonal damage is that which are the nerve fibers that have only axon. There is no myelin sheath. Those are your small fibers. So these fibers have only axon. So if there is an axonal neuropathy, these fibers are especially vulnerable. So then you have small fiber neuropathy, which means you get pain, temperature. Now you can have either loss of pain and temperature, which is numbness, or you can have abnormal pain and temperature, which is paresthesia. And the other kind of nerve fiber that has only small fiber is autonomic nerve. So you have autonomic dysfunction. Okay. Is that clear? So if you have motor weakness and joint position loss, you will think of large fiber neuropathy, or you will think of a demyelinating neuropathy. If you have small fiber and autonomic dysfunction, you will think of small fiber neuropathy or an axonal neuropathy. Okay. So right, so that covers where is the lesion and that covers what is the lesion. So where is the lesion? You will localize which nerve and which limb. And from these two things, you will find out if it's a mononeuropathy, multifocal mononeuropathy, or mononeuritis multiplex, or a polyneuropathy. And what is the lesion? Is it axonal or is it demyelinating? And with the help of these two things, you will figure out why is the lesion. That is the etiology. Now, I don't have the time to go too much in depth about the why, because there is uh, quite a lot of complexity involved. Basically, in each one of these differentials. So in mononeuritis, in a mononeuropathy, you have causes of axonal and demyelinating. In a mononeuritis multiplex, you have causes of axonal and demyelinating. And in a case of polyneuropathy, you have causes of axonal and demyelinating. So in each of these, there are 2-3 causes. Now, I would suggest that you take this chart and you try and fill this table by yourself, because that would give you a reason to open the book, and it will also give you a much clearer idea as to how to progress. Okay, so you have to take this chart. You make 3 columns: mononeuropathy, mononeuritis multiplex, and polyneuropathy. And in under each column, you'll make axonal demyelinating, axonal demyelinating, axonal demyelinating, and under each one, you'll write 3 causes. Okay, and this could be the first homework that I've ever given you, but that's all right. So tomorrow we can actually discuss which are the 3 causes in each one. Now let's talk about evaluation or investigation. Completely depends on the cause. The routine tests that you have to do for every neuropathy patient is you have to rule out diabetes mellitus, you have to rule out HIV, and you have to do a nerve conduction study. A nerve conduction study will help in both where is the lesion, because it will tell us which nerves are involved, and it will tell us what is the lesion, because it will help in differentiating axonal versus demyelinating. And then depending on this, we will go for specific tests. Okay. A rough idea about how to approach etiology is the same mnemonic that we used for our other symptoms, which is vitamins. So you have, I'll give you a few examples of each. So V is vascular, so you have vasculitis. So vasculitis can present as vasculitis is axonal. And I'll write A and DM for axonal and demyelinating. So vasculitis is axonal and usually presents acutely. Now you have infective. Infective, you can have herpes or syphilis. So you can have, yeah, you can have infective lesions. Of course, you can have leprosy, which is the most important one. You have traumatic lesions, which are usually axonal, and they can be mononeuritis, or they can be or they can have polyneuropathy depending on the trauma. You have autoimmune. Now this is very important. Autoimmune, the main example is GBS, and GBS can be both axonal and demyelinating. GBS is Guillain-Barré syndrome, and it is basically an autoimmune condition where our own immune cells are attacking our own nerves, and they're attacking either the axons or they're attacking the myelin sheath. So depending on the target of the immune system, you can get either axonal, which is called AMAN, which is axonal motor neuropathy, or you have AIDP, okay, which is a demyelinating polyneuropathy. Then you can have metabolic, and nutritional. So you have B12 deficiency, or folate deficiency, or B6 deficiency. All of these can cause neuropathy. You have iatrogenic. So drugs. So drug-induced neuropathy is becoming very common, especially your chemotherapeutic agents can cause neuropathy. And you have syndromic. So the couple of syndromes that you have to remember in neuropathy is, see, the most important one, only one you have to remember is CMT, which is Charcot-Marie Tooth, which is a kind of hereditary neuropathy, and it comes in different types. So you have type 1, type 2, type 3, type 4. So type 2 is axonal, and type 1, 3, X, these are all demyelinating. So this is just roughly for you to remember that you can have familial neuropathy. So there could be an entire family presenting with the same symptoms, which is why taking family history is very important. Okay. And again, treatment depends completely on the cause of the neuropathy. So what, after your investigations are done, depending on the cause, you will go for treatment. So you treat the diabetes, you treat HIV. If there's a nutritional deficiency, then you treat that nutritional deficiency. If it's an autoimmune cause, then you treat it with immunosuppression, with steroids. And if it is a genetic cause, then you do counseling, and there are rehabilitation uh, therapies that you can give. I think that covers neuropathy. Is there any questions that you have, or anything, any other point that you want me to clarify? Now is the time to ask. You can ask me directly. I'll just unmute everyone. Yeah. Anybody has any questions, you can just ask. Or you can ask in the chat room. I think that'll be easier. Everyone can see it then. Yes, I did record this lecture, so I'll be putting it up on YouTube tomorrow. Yeah, I had made a channel at some point. I think we all made a channel at some point, but I'm finally putting it to good use. No, not all the lectures. So I recorded the lecture day before yesterday, which was, I think, quadriparesis. I couldn't record yesterday's lecture, but I've recorded today's, and I'll be recording all the lectures after this also. And the ones that I took the first 3 days, so a lot of people had asked me if I can take them again. So I might take that same lecture again, and I'll definitely record those. My channel is called, so it's called Siddharth Warrior. So that's I've just titled it under my name. I haven't called it anything specific, but you can search for quarantine clinics Siddharth Warrior. So you should be able to find it. I have shared I've shared that YouTube link on my Twitter feed also, so you can just check up on that. Okay, so Bhavesh has just asked, what are the positive and negative symptoms in neuropathy? Positive and negative symptoms in neuropathy, and why are they mentioned that way? Okay, all right. So that's a good question. I'll just tell you. So okay, so if your nerve is damaged, okay, so there are certain positive symptoms by which we mean that the patient comes with saying that I have these problems, and there are certain negative symptoms wherein the patient comes and says that I can't do certain things. Okay, so the negative symptoms are basically absence of all the things that a nerve would usually do. There will be absence of that. So your negative symptoms are numbness. You can have sensory ataxia. You have so technically even weakness can be considered as a negative symptom, and your positive symptoms are paresthesias, which is basically tingling and numbness, and sometimes you have something called as pseudoathetosis, which is basically your fingers and hands moving involuntarily because of severe sensory ataxia. So that actually comes as a positive symptom because the patient is unable to control his hands because he is simply not aware of where his hands are. So that is a positive symptom. You can have tremors. Okay, so it's called a neuropathic tremor. So this can be a positive symptom. Basically, any symptom that the patient comes with, which is abnormal because of the neuropathy, any new sign that the patient has is a positive symptom, and the absence of a normal finding is a negative symptom. Okay. Pain would be definitely a positive symptom. Yes. So it is part of paresthesias. I should have mentioned here pain. So basically, paresthesias is a result of your small fiber neuropathy. So you can have pain, and you can also have autonomic symptoms. So autonomic symptom would involve pain. It would involve redness. It would involve swelling. And if there is chronic autonomic dysfunction, you can have deformities in the bone. So Smriti's asked, how do you differentiate a neuropathic tremor from other tremors? So a neuropathic tremor is usually a fine tremor, but just because of just on the basis of tremor characteristics, it's difficult to differentiate. If you find associated neuropathy, then only you call it a neuropathic tremor. So just on the basis of the tremor, it's difficult to differentiate between them. So hang on. Manisha just asked retention. Yeah, so retention of urine, you mean? So yeah, so retention of urine would definitely be a positive symptom. So if you have a plexus injury, then you can have autonomic dysfunction, and that can lead to bladder dysfunction. So it's basically an LMN bladder, and that will definitely be a positive symptom. Yes, thanks, Manisha. So we could do another lecture on bladder because it's like a very confusing topic, and actually even it'll give me also a reason to revise because every few months I think I start forgetting bladder. Bladder is the most fickle thing you can remember. Why don't we use steroids to treat AIDP? Okay, so well, the short answer is that everybody thought that steroids will help because it seems like such an intuitive thing that it's an autoimmune condition and you give steroids and it should help, but it doesn't. So there have been multiple trials and they all showed that steroids aren't really effective. And Another reason is that usually AIDP is secondary to some infection. So either a stomach bug or a respiratory bug. So there is a small chance of infection flare up. So you do the risk benefit analysis, and if there is no benefit and there is some risk, then that's why you don't give. Even so, there are some people who do give a shot of MPS or DEXA, but your studies have shown that steroids itself doesn't help, but there are other immunomodulation like plasma pheresis. So basically your wait, hang on, I'll just show you. So okay, you have your nerve, and you have your myelin sheath, and you have these proteins in the axon called gangliosides. So you have GM1, GM2, all those. So you have basically gangliosides, and you have these antibodies that come and start acting against the gangliosides. So there are basically two forms of treatment that you give. You can give IVIG or you can give plasmapheresis. Okay, so both of this are found to be equally effective. The decision to take one of this above the other is financial and how vitally stable the patient is. But both of them will has been found to be helpful in removing these antibodies and clearing up the immune damage. But steroids have not found to be useful, and it's still not clear why. It's really ironic because uh, an acute, so GBS is an acute condition. So an acute inflammatory neuropathy, there is no role for steroids, but a chronic inflammatory neuropathy, there is a role for steroids. So that is something to remember. So AIDP and CIDP. So CIDP is the chronic version, and in CIDP there is a role for steroids. So actually, one of my immunology colleagues was supposed to join in today. I can't see him. If he was here, I would have asked him to explain this even more. But okay, so I'll see if I can get. So that is something that we can do. I can get my colleagues from other fields. So he's a rheumatologist, so he can explain certain concepts that you need explaining in immunology or gastroenterology. So we can actually think about doing that later, if you like. All right. Did I miss any question? So Smriti asked, can you give an example of deformity of bone? Yeah. So there is something called as CRPS. So that is chronic regional pain syndrome. Okay. So in that you basically have autonomic nerve problem. So what will happen is that your because of some trauma, so there is some axillary damage or elbow damage for some whatever be the reason, there is some nerve damage, and that leads to secondary autonomic dysfunction, and gradually your distal bones start undergoing osteolysis. So and you get all your classical autonomic symptoms such as redness and swelling of your hands. So, and if you do a hand X-ray, then you will find the tips of your phalanges getting absorbed. So that is a feature of chronic autonomic uh, neuropathy. All right, Amit has said, I know many who would be interested in gastroenterology lectures. Okay, all right. Definitely, yeah. So there has to be some way. So why don't we do this? Is everyone on Twitter? Did you all find me on Twitter? Then you can just message me what what clinics you want. Okay, and supposing there are enough people and who are interested in a particular topic, then I can ask someone to come online and clarify that topic. We can take it for like half an hour. Is that okay? Yeah, cardio also. So like I have colleagues in every field, and some of them are very interested in teaching. So we can definitely do this. Yeah, ECG specifically. Yeah, ECG specifically. I'll ask my cardiologist friend to take ECG. Actually, even I wouldn't mind revising. It's What was that book? Shamroth. Are people still reading Shamroth? Yeah, okay. Yeah, I tried reading Shamroth. Cardio wasn't my favorite topic. Can we discuss a case after a session? Sure. Like a case that in the same topic, we can do that. It will stretch the lecture though. So it's, see now, after the discussion, it's already almost an hour. And while we are in quarantine, it's fine. But I don't think any of you want to sit here for an hour. Or maybe you do. I don't know. Maybe you're really enthusiastic. But yeah, we can take a case for sure. Or we can take a case discussion separately. We can, like after we finish the basic theory, then we can take a case discussion separately. We can even have one person uh, take the case. So we can even have one person make make a case presentation, come on video, present it to me, and we can discuss it, and the rest of you can listen. That would also work. So there's really no, yeah, nothing stopping us from doing that. Definitely. Yeah. Even I think a separate case discussion makes sense because there won't be enough time to do justice to a case actually. Because case taking will go into history. Okay, so especially online, a case taking will basically go into the depths of history taking and how do you approach negative history. So your main history taking lies in your negative history. So each each symptom and each kind of diagnosis has a separate negative history. So we can discuss that for sure. Anything else? So tomorrow we'll be doing myopathy. Uh, Myopathy is one of those cases that at an MBBS level, it is less important because it's very unlikely that you'll get a myopathy case. But it's still good to know. And I want to take it because it sort of completes the anatomy. And after that, we only have cerebellum. Neuromuscular junction, I'm not going to take because it is only theory. There's not much of, a diagnostic this because if you if you can evaluate for LMN and you've ruled out a neuropathy and a myopathy, then you're already thinking of neuromuscular junction. But we can take theory separately. So see, basically, I'm open to taking anything, but you have to tell me after this because after tomorrow's myopathy and day after tomorrow cerebellum, um, after that, what we take is sort of up to you. So you tell me what you're interested in. On Sunday, we won't be doing a clinical lecture. On Sunday, we'll be doing a non-clinical neuroscience topic. I just put out a poll and we'll be discussing memory. So how the brain learns, how the brain remembers, and what are the circuits involved, what are the neural circuits involved in memory. So there'll be a lot of neuroscience, there'll be some philosophy about memory. So why is memory so important? So Sunday evening will be discussion on memory. Okay, and on Monday we'll take cerebellum. Is that okay? Would you guys be interested in memory? Then you can also join in. Okay, awesome. Great. Today's been fun. I remembered to record it, so I'll put it up on YouTube tomorrow. Check out my channel. I think I'm supposed to say should like, share, and subscribe. So please go do that. And I'll see you tomorrow. Bye bye.